That could be catastrophic. That could actually kill someone. Imagine having 10 cups of coffee and then going bungee jumping. What would you do if you checked your blood pressure and it was 220 over 154? Would you panic, call 911, or just try to wait it out? We're going to see how AI responds to this specific situation. Along the way, we'll be giving ChatGPT a scorecard that will lead to a final grade at the end. Blood pressures in the 200s can sound extreme, but as a hospital doc, I've sat next to patients who have these kind of numbers hundreds of times. You have to act fast and you don't want to make the wrong call. So the big question is AI up to the challenge? Let's see. Okay, let's ask ChatGPT this exact question. Okay, here we see. So they call out the blood pressure. So it's extremely high and considered a hypertensive crisis. Right now, they are interacting with the person who's asking this question as a patient, not as a physician. So they're trying to use verbiage that is easy to understand. So they call it a hypertensive crisis, which is true in my mind. So I fully agree with their initial assessment here. You need to go to the nearest emergency room immediately because when your blood pressures are 220, I mean, you can blow a gasket. This is the correct response. Can I do anything else? Is not something you want to monitor at home. Again, they call out hypertensive emergency. Before they'd said hypertensive crisis here, which in some ways we use fairly interchangeably in the medical field. And now they're actually bringing out symptoms. So before they were just saying go to the ER, but now they're saying, hey, if you have any of these symptoms, you really need to go get checked out, which again, very much agree with. Even without these symptoms, you need to have this blood pressure managed. So again, I fully agree with this. I can't say that this is wrong. This is something that we learn in medical school, and there's a clear distinction, and let's see if ChatGPT gets it correct. All right, so if your blood pressure is 180 over 120 or higher, and there are signs of end organ damage, this is what we call hypertensive emergency. And they say most serious, which I think is fair. Here, hypertensive urgency, same distinction, but no immediate signs of organ damage. So I think they do a really good job in distinguishing hypertensive emergency and hypertensive urgency. Both important, but the major difference being that emergency, you have evidence of end organ damage, either by symptoms, labs, imaging, or other findings. Now let's ask them, how do we get in this situation? What exactly happened? This could be from lifestyle, health conditions, or medications. All very true. Okay, now it looks like they're going to give us 10 possible reasons why we could have ended up in this predicament. So I would call out stress and anxiety, number 3, 4, diet, and obesity or lack of physical exercise. All of these things are lifestyle changes and lifestyle habits that can definitely be modified and help improve your blood pressure without having to take any extra pills. Chronic kidney disease, CKD, can absolutely cause blood pressure increases, especially over time. Poor sleep, again, another lifestyle issue. Going back to the hormonal imbalances, so they call out hyperthyroidism, Cushing's, and pheochromocytoma. I would say that in my 8 years of medical practice, I have seen pheochromocytoma only twice. And I think only once was it actually the cause of a hypertensive emergency. So we have a saying in medicine, which is when you hear hoofbeats, think horses, not zebras, right? It's way more likely to be a horse than a zebra. Common things are common. And so pheochromocytoma is definitely something we have on the back of our mind, but it's very rare. And what it is it's a tumor of the adrenal glands, which causes you to have incredibly high levels of adrenaline. So your adrenals secrete adrenaline, right? Things like epinephrine and norepinephrine. So if you imagine having 10 cups of coffee and then going bungee jumping right before you jump, all of that adrenaline in your system, there's an extreme amount. And that's what this tumor does, is it randomly secretes huge amounts of adrenaline where you're very pumped up, your blood pressure skyrockets, and you can end up with hypertensive emergency or urgency. So again, this is a little bit of a zebra, much more rare, but is a true diagnosis. Now let's go over number 9, substance use, which can be common for many people, right? Because yes, you have cocaine and amphetamines, things that hopefully you're not using, but also common things like alcohol can cause increase in blood pressure over time. And more specifically, people who drink alcohol frequently and go into alcohol withdrawal, who come in with the 180s, 200s, really jittery, having high blood pressure, high heart rates. This is something that we see very commonly, unfortunately, in the hospital. So now I asked ChatGPT, my blood pressure was normal 1 week ago. What could have caused it to spike up so quickly? And their response is fairly similar, so I won't comment more on this, which is things like stress, pain, illness, medication changes or missed doses, dietary things, dehydration. Usually we think of this, let me see what they actually read. Dehydration can cause you to retain salt, which increases your blood pressure. It can reduce your volume of blood circulating, which raises blood pressure. If you have a busy week and haven't been drinking enough water, or if you've been sweating more, dehydration can play a role. I think this might be the first faux pas or incorrect thing that I'm seeing here. So almost universally, if you have dehydration, your blood pressure is going to be low, right? If you have not enough blood or plasma volume circulating in your system, the chance that you're going to have high blood pressure as like the fifth most common cause, I think is really unlikely. I'd say 95% of the time you are going to be hypotensive. You're going to have low blood pressure, not high blood pressure. So I don't quite agree with this. I would say this is perhaps a misstep. I certainly wouldn't want to tell patients or call out dehydration as a common cause of high blood pressure when it usually causes low blood pressure. Let's have a slight transition here. So all of the aforementioned questions that we've asked have been a non-medical person asking ChatGPT for advice. Now let's switch the situation a little bit, and we'll have myself as a healthcare provider, as a physician, asking questions and kind of troubleshooting their actual medical responses. Things would you do? Question. Here are the diagnostic steps and immediate actions they would recommend. Check for symptoms. Okay, big thing. All right, and it's also one of the quickest things you can do is just kind of go through review systems, ask them if they're having chest pain, shortness of breath, confusion, neurologic changes, numbness, weakness, all of these things that we alluded to before. Oh, great. So now they're calling out things like a wide pulse pressure and aortic dissection. We will talk about these in a little bit. These are routine tests that we get for patients who come into the emergency department. They're kind of the bread and butter. They will cover the vast majority of issues that most patients come in with. So I would say these are somewhat non-specific kind of stock labs, but they're good ones. And I think they're relevant to anyone who comes in with this type of blood pressure. Okay, so I would agree with all of this. I think a thyroid test is very reasonable and it's a common test. This one, again, it's slightly on the zebra realm. I think for most patients who come in with this high blood pressure, if it's especially without a pre-existing diagnosis of Cushing's or aldosterone issues, we probably would not jump to a cortisol or a renin aldosterone right off the bat. Certainly, I don't think it would be ordered by the emergency doctor, possibly by the hospital interns, the hospitalists such as myself, when patients move upstairs. Other diagnostic tests, an EKG to rule out acute myocardial infarction. So they want to make sure that you're not having a heart attack because of your high blood pressure. I think this is fair. I would say that there's another reason why we would get an EKG in this scenario. And so I'll prompt them in 1 second to see how they respond. I really want to talk about this segment where they say blood pressure within a safe range. Ideally, lower the systolic blood pressure by no more than 25% within the first hour. So this point is really important to make, which is you treat people who have had chronic high blood pressure very different from those who have had a more acute change. So if someone is known to have blood pressures that usually are in the 160s to 180, and they just kind of randomly spiked up to the 200s, this is someone whose body is adjusted to those high blood pressures, right? So if you go from your usual 180, which I'm not saying is good control, but if someone is chronically there, maybe they don't take medications, perhaps they're not necessarily following all those lifestyle modifications that we mentioned before, healthy diet, good exercise, good sleep, perhaps that's not the case for them. Their bodies are adjusted to having blood pressures in that range. So if you were to drop them quickly, that could be catastrophic. That could actually kill someone, right? So if you say, oh, but a normal blood pressure is 120, let me take them from 180 to 120 as soon as possible, big problem. Okay, because again, their vasculature, all of their organs are used to having blood pressures in that 180 range. So if you drop them by 60 points rapidly, they're going to lose perfusion. The amount of blood flow that they are accustomed to having and need to have to keep those organs happy, if you tank it, it's going to be an issue. I guess one way you can compare it is if my normal blood pressure is 120 over 60, and all of a sudden you drop my top blood pressure from 120 to 60, right? That's 60-point difference. I'm going to pass out, right? So if someone goes from 180 to 120 very quickly, they could have a similar problem. So what's really important to know is when a healthcare provider is treating someone for hypertensive emergency and is lowering their blood pressure, you do try to lower it within the first hour a certain amount, but overall within a 12 to 24 hour span, you try to lower it by around 25%. You don't want to overcorrect too rapidly, especially when people are adjusted to that blood pressure level. Let's push them a little bit further on this EKG. So they're talking about we are getting this EKG to rule out an acute myocardial infarction or heart attack. So I'd say, why are we getting an EKG? Any other information that it could provide us? All right, so this was the point that I was hoping that they would get to, and I'm glad they eventually did. Long-standing hypertension is a major risk factor for left ventricular hypertrophy. So this is when your heart is pumping so hard for so long against high pressures, it becomes beefy, right? Like if you think of someone doing bicep curls over and over and over again, they're going to grow that muscle. And so when your heart is pumping that hard for that long, it starts to grow. And in this case, it's not necessarily a good thing. For your biceps, maybe that's an aesthetic thing. You're stronger, it's great. But for your heart, there's a fixed amount of space, and there's also a certain amount of function and filling need that you want to preserve. And so when your heart kind of gets worked out uncontrollably, that's not a good thing. So here, may indicate the heart's long-term adaptation to elevated blood pressure. I think the focus is not where I would have it be. I would have this much higher. And again, the reason is the way you treat someone who has chronic elevated blood pressure versus just someone with normal blood pressure who's like all of a sudden really stressed, has a panic attack, and their blood pressure shoots up. You treat these two things very, very differently. Left ventricular hypertrophy cues you into, oh gosh, let me treat this person as someone who is chronically elevated. It's a different treatment pathway. And so I would have liked them to be a little bit more clear here in saying that LVH tells you that this is a chronic issue, which would then change the management. So that kind of logical leap is not strongly made here. So now let's take it to the bedside. Let's pretend they are there, and we'll say, what physical exam findings would be important? Okay, so they're working us through the cardiovascular exam, the neurologic exam, renal exam, vascular, eye exam. So I think this is a good kind of organ or system-based approach. What is interesting to me is here, they've actually called out aortic dissection a few times, which is pertinent. So anyone whose blood pressure is so high, every heartbeat almost has a shearing type effect. So when there's so much high pressure and high force through the aorta, it can cause damage and lead to a dissection or a separation of that actual big blood vessel. That is something that is incredibly dangerous, life-threatening, and is not a rare thing. It is not a zebra. It's something that unfortunately is, I want to say common, but is not rare. There's a much easier way we can find out or evaluate if someone may be having an aortic dissection based off of physical exam. Let's say you have this long pipe, and at the top you have the branching points where your blood flow goes to your arms, and then you go down the pipe, and then lower on you have branching flow where it goes to the legs. So if in between there's some sort of like vice or clamp or some restriction or dissection in the middle between that top arm and the bottom legs, your top blood pressure will be normal to high. And then below that kind of clamped vice, dissection, irritation, cut off to the blood flow, you'll have lower blood pressure to the legs. So when someone has any concern for dissection, it is very important to get blood pressure in both arms, both legs, to make sure that all of them are generally similar. What would someone's hospital course look like who had hypertensive emergency? So immediate stabilization within the first hour. You're trying to control the blood pressures and get them in slightly more of safe range, again, without tanking them too much. Frequent blood pressure measurements. This is correct. In fact, if someone has true hypertensive emergency that is on various IV drips in the ICU because they require that much monitoring, you will often have something called a arterial line. So instead of an IV, which goes intravenous into your veins, you have another similar thing to an IV that actually goes into your artery and directly measures your blood pressure continuously. So rather than checking every 5 to 15 minutes, it's literally a second by second continuous monitor of your blood pressure, which allows you to very easily, more quickly titrate the medications to drop their blood pressure in a safe, appropriate range. Okay, let's get into this point, which is transition to long-term management. They would try things like lisinopril, losartan. These are somewhat sister type medications, calcium channel blocker, beta blocker, or diuretic. My personal opinion, I think there are different or better blood pressure medications they could have suggested. Each one of these blood pressure medications is tailored to someone's overall picture. And it's based off of their side effect profile. It's based off of what the patient needs. These two, lisinopril and losartan, can be very good medications, but if you have evidence of severe kidney damage, we would not be using them at all. Amlodipine is a common good medication, but it can have a side effect of causing swelling, especially in the legs. And so if there's any concern for swelling, congestive heart failure, or from chronic venous changes or venous insufficiency, might be one that we shy away from. I don't love how they have beta blocker here, metoprolol, as a common transition to an oral hypertensive medication. Beta blockers as a class are good medications that are often used for heart protection and heart-related conditions, but mostly metoprolol specifically, and most beta blockers, will lower your heart rate much more than they will affect your blood pressure. And so if I have someone who comes in with hypertensive emergency, a beta blocker, metoprolol, is not a medication that I foresee them going home with, especially as a primary blood pressure medication. I don't love this response here. So all in all, I think AI did a fairly good job in assessing the situation, giving some initial recommendations, walking us through what a ER hospital course could look like. I do think there was some gaps in their reasoning, which is to be expected at this point. I know the technology will keep getting better and better. Right now, it's really the questions that are important, right? You have to know what to ask ChatGPT, how to prompt it. I think from a clinical reasoning standpoint, ChatGPT actually did fairly well against certain things that I would disagree with that I called out previously. I would say ChatGPT and these AI chatbots, they're fantastic at knowing the guidelines, having kind of evidence-based care, and going in a very rigorous kind of textbook approach to care. In my experience taking care of patients with hypertensive crisis and emergency, sometimes you need to find out the why. Like, why is this happening? And that's something that's not in the textbook. Like, I'll give you an example. I remember taking care of a middle-aged lady who was fairly healthy, and she came in super high, right? Like in the 200s. And I could tell she was just very anxious. And even though ChatGPT called out anxiety, there's really not a further thought of what's going on in the patient's mind, right? What am I actually seeing human to human? What are these small little cues that are hard to pick up otherwise? And I could tell there was something that was bothering her. And so I just asked her, why do you think your blood pressure is this high? And she really leveled with me, and she's straightforward. She said, my sister died a year ago to this day, and I can't shake that feeling, and it's really on my mind. And so really talking with her a little bit more about that, and kind of understanding her and hearing her out and almost playing a therapist role, it was much more important than all the IV medications that I could throw at her. These are things outside of the usual textbook that, would take a human to pick up on. And so I'd like to at least say that there are things that we still add. I, of course, think that we do. And again, I think AI will get there eventually where they're able to do a phenomenal job. But right now, using them in synergistic fashion and almost as like backup or little reminders can be helpful. So my overall score would be an 8 out of 10. I think there were certain things that were missed, but I also think there were certain things that weren't really called out or emphasized that should have been. And so that's why I'll probably dock a few points. But I really look forward to doing this more. This was a lot of fun for me. I hope you gained some information. I hope it was educational. If you learned something from this breakdown and you want to see how AI reacts to the next one, go ahead and subscribe. Join us. I'd love to see you next time.